Perfect.
We'll talk about what CML therapy is for the vascular system. So Dr. Mirault is MD, PhD, board certified in internal medicine with a tremendous specialization in vascular medicine. He was among the early ones in 2011 as vascular specialist collaborating with a very famous hematologist, we hematologists know her quite well, Tristan Mirault, to report on the vascular complications during myeloid therapy, about which you hear from him, the second generation TKI, used with CMA. He co-authored several publications on that topic since then. He works as a famous physician at the European Georges Pompidou Hospital in Paris and leads the National Reference Center for Rare Vascular Diseases. So it's a real pleasure for us to have you here, and we're looking forward to hear you talk about what does CMA therapy link for our.
Thank you. I will first thank the invitation from Professor Zaza Yakupishvili and Dan Gina. And sorry for my voice, but I got a cold 2 days ago. So I try to be understandable as much as I can. So here are my disclosures. Our unit is a vascular medicine unit, so we take care of patients with polyvascular disease, multi-bed vessel disease, critical venous ischemia, and refer the patient for either endovascular surgery or vascular surgeon for bypasses. And also we take care of deep vein thrombosis with the new direct anticoagulant, and also rare vascular disease. We are the National French Reference Center for that. And for example, we take care of bicuspid aortic valve, and we have a collaboration with Hadassah Hospital in Jerusalem. So you know that the ESC published last year recommendation or a statement paper on oncocardiology. And of course, the increase of TKIs are tremendous during the last decade. From the imatinib in 2001, which was a real breakthrough in the chronic myeloid leukemia treatment, we see a lot of new TKIs rising up since the last decade. The target of this treatment is broad. You have small molecules targeting, of course, the BCR-ABL, which is the transcript in the CML, but numbers of kinases are targeted for these small molecules, and the VEGF also, and the RB2. But there is lots of off-targets of these targeted therapies. So, for example, the ITKs used in CML, like imatinib, which was quite specific for the ABL kinase. The new TKAs are not so specific. For example, bosutinib, the last one, is very broad, and ponatinib also, and they are targeting it's not VEGF, PGF, c-KIT, etc. So there's lots of cardiovascular side effects of this new therapy in chronic myeloid leukemia. For example, myopathy, rhythm issues, ischemic cardiopathy, but also arterial thrombosis and venous thrombosis. I will focus my presentation on the tyrosine kinase inhibitors, and especially on nilotinib, ponatinib, and the two new ones, dasatinib and bosutinib. So chronic myeloid leukemia is a disease caused by the translocation of chromosome 9 to 22, and there is a new kinase, BCR-ABL. So the first targeted therapy that inhibited this tyrosine kinase was imatinib in 2001, and it was a real breakthrough for the care of this patient because they didn't need any graft transplantation. Then after you had the second generation TKAs, and now the third generation. With this new drug, you have a deeper molecular response, but you also have more cardiovascular side effects. So let's start with the clinical case. This is a 60-year-old man that we received in April 2010. He had cardiovascular risk factors, high blood pressure, dyslipidemia, tobacco consumption that ceased since 1998, and chronic myeloid leukemia since 2005. First treated with hydroxyurea and then pegylated interferon imatinib, but due to side effects with the imatinib, he was receiving nilotinib since 2008. Actually, we received it in 2010, but 1 year previously, he was started with a claudication of the lower limb. And in January 2010, there was a critical limb ischemia with a wound of the heel. So he got surgery and angioplasty of the left common femoral artery and superficial femoral artery. Several angioplasty needed to be done until we stopped the nilotinib therapy. And in 6 months, he healed the wound, and there is no new angioplasty required. This was based on the publication in 2011 of this group from Austria of 24 patients with CML, chronic myeloid leukemia, and 3 of them developed PAD with repeated angioplasties. One, another PAD, myocardial infarction, hematoma, subdural hematoma, and 1 sudden death. Almost 30% of the patients presented arterial occlusive events. Another publication of 179 patients with CML, 11 of them developed arterial occlusive events, and only 1 of these patients had no cardiovascular risk factor. They were actually 4 with tobacco use or high blood pressure, diabetes mellitus, or dyslipidemia. There is an interaction of the classical cardiovascular risk factors and the arterial occlusive events under TKIs. Peripheral arterial disease, of course, is increasing with age. So that was the answer of the company. It was saying that your patients are more than 65 years old, so it's normal that they have PAD. Also, PAD is increasing with classic cardiovascular risk factors, like tobacco consumption, diabetes, hypertension, and age. Every people over 65 years old should be detected for PAD. And you see that between 50 and 64, if you have any of the classical cardiovascular risk factors, you can have a PAD, and below 50 is mostly due to diabetes. Pulse examination should be performed. On-call index to measure the pressure at the wrist, the pressure at the arm, and the pressure on the lower limb. And there is a recommendation of the ESC. Newest recommendation will come next year. So for asymptomatic PAD, you treat the patient with classic medical therapy, ACE inhibitor, aspirin, statin, and you control the cardiovascular risk factors. If there is symptoms, you first start with supervised rehabilitation, and the worst case is critical limb ischemia, and you do all you can to do a revascularization. So based on that, we first published in Leukemia in 2013 our results of the evaluation of every chronic myeloid leukemia patient in our center, and with the ABI, on-call index, and echo duplex ultrasound. And what we found, comparing first-line imatinib to first-line nilotinib or second-line nilotinib, was the increase of the abnormality of the ABI with nilotinib therapy, either first-line or second-line, compared to the first-line imatinib therapy. And that was the same for the findings on the duplex ultrasound. Is there any metabolic disturbance due to nilotinib? Well, we conducted this study evaluating the plasma fasting lipids at baseline 3, 6, 9, and 12 months after initiation of nilotinib. patients didn't have any lipid-lowering therapy. So there is an increase of the total cholesterol, the LDL cholesterol, but also the HDL cholesterol. If we are talking about ponatinib, another TKI, there is no increase at 3 months of all of these cholesterol parameters. So, based on the recommendation, ESC recommendation, 15% of the patients should have lipid-lowering therapy, but at 3 months, up to 41% would have a lipid-lowering therapy. So now we are saying that it's a requirement for patients using nilotinib to check out the cholesterol level and to treat according to the ESC recommendation. There's also a slight increase of glycemia at 1 hour after the intake of nilotinib at 3 months here. And so, due to nilotinib, the physiopathological hypotheses are numerous. Of course, maybe an increase of the glycemia will lead to diabetes mellitus, the increase of cholesterol, maybe interaction with other kinase like CKAT or DDR1, leading to the increase of arterial occlusive events and PAD. So we try to separate patients based on the 2012 European Cardiovascular Disease Risk Assessment model. So you can split patients between high and very, very high risk based on previous documented cardiovascular disease or low or moderate risk. This is the cohort of the patient. So all of them presented hypertension, diabetes mellitus previously to the initiation of nilotinib therapy. And 16 of them were in the high and very high risk group. So all nilotinib treated patients presented arterial occlusive events. And at 2 years, you have almost 40% of patients that present one arterial occlusive event. If you separate them between high, very high risk and low, moderate cardiovascular risk, you see that, of course, the high and very high risk have higher survival and a higher rate of arterial occlusive event. It's stating the obvious, or in Hebrew you would say, I try to already convince people, because it's normal that high and very high cardiovascular risk patients have a higher rate of arterial events. But if you compare the same group of patients with high and very high risk between imatinib and nilotinib, you see that there is a direct effect of nilotinib on the arterial occlusive event. So there is an interaction between the classical cardiovascular risk factors and the TKI you are using. Finally, we get the results for the NSND trial of the nilotinib, and at 5 years, and you see they conclude with the same results. Imatinib has a low rate of arterial occlusive event compared to nilotinib at 5 years, and there is a dose response because at 400 twice daily and 300 twice daily, you see there is a higher rate with a higher dose. And last year, they also published the same idea that the patient with the higher cardiovascular risk have the higher risk of developing events with nilotinib therapy with the Framingham classification. So high Framingham risk category, you have almost 24% of the patients will develop arterial occlusive event with nilotinib 400 milligrams twice a day. So it's very high. So now there is a new paradigm. In France, with the Delphine Réa, which is a hematologist at the Saint-Louis Hospital, we published with this recommendation based on 2 classifications, because these new TKA are very efficient to control CML. So For patients with a high risk of developing acute leukemia with a high risk so-called score, it will be a benefit to get these new drugs. So at high SOCO, if you have a low or moderate cardiovascular risk, of course you will use nilotinib instead of imatinib. If you have a high or very high cardiovascular disease, you may discuss nilotinib or use imatinib. But if you are a low risk of acute leukemia, low SOCO score, and you have a high, very high cardiovascular risk of cardiovascular disease, then we should use imatinib and not nilotinib, because the risk of cardiovascular disease is higher than the risk of acute leukemia. So before installing the therapy, you should evaluate the patient. And I reinforce here the presentation of Professor Klempner, that this is the key point, that you have a global view of your patient and take into account the cardiovascular risk it presents. So you can use a new classification of the ESC in 2016 and classify your patient according to the very high cardiovascular risk or high cardiovascular risk. And then you can use a score chart leading you to the risk of cardiovascular mortality at 10 years. And then you apply this chart to know what is the level of LDL cholesterol you should reach, either with lifestyle advice, or introducing lower cholesterol therapy. Also, you will ask for stopping smoking or arrange a diet, physical activity, control the body weight. If there is a high blood pressure, treat it and control that the target is obtained. And of course, the lead therapy if recurrent. During therapy, the patients are examined every 6 months by somebody who takes the pulses, who measures the pressures. And if there is anything new, you should address the patient to a cardiologist or vascular specialist. So when you have a cardiovascular event during the therapy, we should stop nilotinib therapy immediately. I will show you an example. And address the patient for cardiovascular specialist to take the best medication that he could have and the best treatment that he could have. So we published this case of a 55-year-old man with chronic myeloid leukemia. He had 4 years of imatinib treatment and a rapid increase of the BCR-ABL transcripts levels. So there were a change from imatinib to nilotinib. 400 milligrams twice daily, and he had no cardiovascular risk factors. We assessed the patient the first month of the therapy with nilotinib. So the score risk was less than 5% at 10 years. The LDL cholesterol was 0.8 gram per liter. The HbA1c was 5.7, and the ABR were normal. 12 months after that, and I saw him every 6 months, he had a right leg claudication with a decrease of the ABI. And actually, the SFA, the superficial femoral artery, where stenosis are even occluded at the hunter, but he also presented stenosis of the celiac trunk and of the superior mesenteric artery and of the left renal artery. So this is a diffused lesion of the vascular tree due to the drug, because he had no risk factor to develop this kind of lesion. In that case, we stopped immediately nilotinib. This patient couldn't have dasatinib or imatinib because of the mutation he presented, and we didn't have the bosutinib yet available. So the hematologist tried again imatinib in hope that the mutation disappeared on nilotinib. And actually it was successful, and for our part, we treat the patient with ACE inhibitor, aspirin, and rosuvastatin. 3 months after, he had no claudication anymore. Of course, the artery is still occluded, but he developed arterial collateral network, and now he has a normal ABI and a low LDL cholesterol. So there is a lot of cardiovascular event with nilotinib therapy, and rate ranged from 1.2 in LS trial to 33 in cohorts, and now we have new drug, which is ponatinib, and it seems that the rate of PAD is also high, between 5% to 12%. So let's talk about this new drug now. There is a phase 2 trial, PACE trial, in which patients were treated with ponatinib, and you can see that at 12 months they developed serious adverse event due to cardiovascular, cerebrovascular, peripheral arterial disease at almost 10%, and at 24 months it's above 12% of the patients. So there's a 1.7-fold increase in exposure over the 1 year more treatment, and there is a real increase of serious adverse events on the cardiovascular system. One explanation for that is ponatinib has an anti-VEGF inhibitor action, and so you can see an increase of high blood pressure during treatment with ponatinib. Patients that had a normal blood pressure before treatment move to grade 1 hypertension, grade 2 hypertension, even grade 3 hypertension during ponatinib therapy. And you see that it's also give higher blood pressure for patients already treated for their high blood pressure, even with patients at grade 2 before ponatinib therapy, they reach the grade 3 grade of the high blood pressure. So 84% of patients had elevated blood pressure at baseline, and 67% patients experienced increase of their blood pressure on the study. So hypertension is a very heavy adverse event during ponatinib therapy. And again, if you look at the patients who are going to do arterial thrombotic events to those who are not going to have arterial thrombotic events, you see that, of course, they are younger if they don't have any thrombotic event and don't have any previous cardiovascular disease. Impact of dose of ponatinib. Cardiovascular events are representing here in this meta-analysis of the 3 trials with ponatinib, the phase 1, phase 2 trial, and the shortened phase 3 trial EPIC due to vascular toxicity. So if you look at the different cardiovascular events, you see that there is cardiac failure, and with an odds ratio with increasing of dose intensity of 2.3, but also arterial occlusive events of 1.7, cerebrovascular events of 1.4, peripheral vascular events of 1.2. And if you look at the number, you have 102 patients with arterial occlusive event over 671 patients, so it's a lot. Again, there is a link between the dose of the treatment, the history of diabetes, the history of previous cardiovascular disease. Let's have a look to other TKI, dasatinib. It's the second generation TKI. There is no arterial occlusive event with dasatinib, but you should be aware of the increased rate of pulmonary arterial hypertension and pleural and pericardial effusions. So in these 2 papers, the number of patients rise from 0.5 to 6% with pulmonary arterial hypertension. So last one, bosutinib, with this publication last year, for patients in failure of imatinib plus dasatinib or nilotinib. Here are the adverse events of this drug, and the cardiac events are here. So there is a lot of pleural effusion, 12%, and cardiovascular events, 11%, related to the therapy, mainly due to pericardial effusion and cardiac failure and hypertension and rhythm control defect. So there is no really ischemic issue, but more a rhythm issue due to the bosutinib. So the profile is similar to the dasatinib. At the conclusion, the risk of developing complications during tyrosine kinase inhibitors is a balance between the type and the dose of the tyrosine kinase inhibitor you use. There is high cardiovascular risk with nilotinib and ponatinib. There is a low cardiovascular risk with dasatinib and bosutinib. And also by the personal cardiovascular risk factor of your patient. So you have to take the patient in its whole to look at the risk factors: smoking, obesity, diabetes, high cholesterol, high blood pressure, and treat them if needed. Individualized risk assessment is really important to give the best therapy for your patient, because the new TKIs are much more efficient to control CML, but there is much more cardiovascular events. So for young people of 40 years old with no cardiovascular risk factors, it will be a great benefit for him to get a new therapy, a new TKI, so the CML will be perfectly controlled. To that extent, French recommendation will have decrease in the cardiovascular risk during nilotinib treatment, and this is what we see since 2 years. There is much less patients with PAD over nilotinib therapy. But we are conducted a prospective cohort to show that. And the mechanism of the vascular event during nilotinib and ponatinib is not completely explained, actually. Of course, ponatinib has a VEGF effect, so you have an increase of high blood pressure, of the blood pressure. But nilotinib doesn't have any VEGF effect. So I saw this morning Oren Caspi with the cardiomyocytes with testing ponatinib and nilotinib. You can have the increase of the QTc, but you don't have the effect on the vascular tree. So maybe it would be interesting to see if we could get other cell types and try this molecule. For our part, we'll try on ApoE deficient mice, nilotinib and ponatinib compared to imatinib. And of course, human studies are required to design new biomarkers to see if we can have a precise profile of side effect coming on for a patient on each TKA, and of course histopathology of the lesions, because we don't know exactly what are these lesions that I'll show you. Okay, thank you.
Thank you very much. Any questions from the audience? I have one comment and one question. First of all, for those in the audience who are not hematologists, in Israel, dasatinib is approved for first-line treatment. And I think in France it was just recently approved. So, because in your algorithm of how to choose the best TKI, you don't see dasatinib, right? You have high respect to cardiovascular risk factors. I think you choose dasatinib and nilotinib, but I guess you didn't have a choice.
That's right, because when this recommendation were published, there was no dasatinib in first-line therapy. But the way to think is the same. Evaluate the risk of acute leukemia, or the so-called score, and evaluate the risk of cardiovascular event, and you have your balance. You know that dasatinib does not expose your patient to high cardiovascular ischemic events, but more pleural effusion and pulmonary arterial hypertension. And you know that ponatinib will increase heavily the risk of cardiovascular occlusive events.
And the other question is, we know that the mechanism of pathogenesis of nilotinib instead is usually through atherosclerosis, and that's why we think later. But with ponatinib, we know that it can occur after 8 months. So could you elaborate a little bit on the mechanism of ponatinib instead?
It's in nilotinib, it also occurs in a few months. As I showed you, in 12 months, our patient occluded the superficial femoral artery, stenoted the celiac trunk, the left renal artery, and the superior mesenteric artery. So what we know is that there is an interaction between the classical cardiovascular risks factor and the drug, but there is also an inherent potency of the drug to make these lesions. So, for patients with cardiovascular risk, you take a great risk to put this drug, but in patients with no cardiovascular risk, there is a little risk of getting these lesions. So there's still a mechanism that we don't understand with nilotinib and ponatinib on how these lesions occur.
Okay, thank you very much. And now it's my pleasure to invite Professor